My name is John Sevransky. I'm the editor-in-chief of Critical Care Medicine, and it's my distinct pleasure to have two of the associate editors for Critical Care Medicine, Bram Rochwerg and Aarti Sarwal, here with me to talk about one of the articles that will be published in the April edition of Critical Care Medicine, Transfusion Practices and Traumatic Brain Injury, a systematic review and meta-analysis of randomized controlled trials. So maybe I can start out, Bram, by asking you, as a methodologist, can you talk for a moment about the role of systematic reviews and meta-analyses, especially when a treatment signal for large randomized controlled trials don't all go in the same direction?
Thanks, John. My pleasure to participate in one of these editors' videos again. Thanks for the invitation. You know, beyond my role as an associate editor, I also help with guideline methodology as well, and have helped with FCCM guidelines as well as a number of other societies. And, you know, when it comes to informing practice and informing recommendations, meta-analysis of randomized controlled trials are sort of the top of the top. When you think through that evidence pyramid that maybe we all learned back in clinical epidemiology class associated with medical school or clinical training, that top of the pyramid is a meta-analysis of well-done RCTs. You know, obviously that entails the fact that they are well done, and, you know, detractors of meta-analysis always fall back on the fact that, sure, in a perfect world, a meta-analysis of well-done RCTs is fantastic, but there's always important differences amongst the RCTs that might influence one's ability to sort of statistically pool them together. I think for the most part, these are over-exaggerated, these differences. And, you know, even subtle differences in eligibility criteria, in the intervention, comparator, any of the PICO components really, rarely manifest in differences in signal. So, you know, which we call statistical heterogeneity. And so, you know, these subtle differences in methods, approach, or eligibility, you know, usually translates into a consistent signal when you look at the forest plots, or maybe not a perfectly consistent signal, but a generally consistent signal. The challenge you've brought up is what to do in the situation where you see a significant amount of statistical heterogeneity, which can be calculated, or even just visually, if you look at the forest plot, if you see that the signal is on either sides of unity or the treatment effect. And, you know, in grade world, grade methodology world, we call this inconsistency. And this is a reason to be less trusting of the data, is that if you see, you know, all the studies in the signal of benefit or all the studies in the signal of harm, you'll trust that conclusion from the meta-analysis more than if you see inconsistencies amongst it and a high degree of statistical heterogeneity. I guess, you know, if you see statistical heterogeneity, John, you know, one of my first steps will be to explore that heterogeneity with things like subgroup analysis. Maybe one of the studies only looked at adults, some of them looked at peds, or there's other structural differences amongst the studies that might explain that heterogeneity we're seeing. Let's come to the specific example of this meta-analysis, because that's what sort of triggered this discussion. And, you know, I guess if you read there's two big studies, although the meta-analysis included 5 RCTs, there's 2 big studies, both of them published last year, the Tacconi trial and the Turgeon trial, TRAIN and HEMOTION. And if you look at those 2 trials and you look at the conclusions in JAMA and New England Journal, they do on optics appear discrepant. The TRAIN trial in JAMA suggested that a liberal transfusion led to better neurologic outcomes. HEMOTION showed no difference. But if you look into the details, and the forest plot in figure 2 in our publication in CCM as part of the meta-analysis demonstrates this nicely, is that the point estimates for those 2 trials, when you look at neurologic outcomes, are pretty aligned. Yes, the confidence interval just crosses the line of no effect in the HEMOTION trial, but the point estimate is on the side of a favorable outcome with liberal transfusion strategy in both trials. And so, you know, although here one might look at it on a 20,000-foot view and say these are discrepant trial results, there is a very low degree of statistical heterogeneity when you look at this forest plot, and findings consistent with benefit of a liberal transfusion strategy when it comes to neurologic outcomes. There's a degree of uncertainty given this, you know, the fact that the confidence interval just touches 1, but this is not one of those situations where I think we have important inconsistency once you dive into things. I'm interested to hear Aarti's perspective on whether this changes her practice as a neurointensivist, but I think that this is a great scenario to do a meta-analysis and pool results.
Thanks, Bram. And that's a wonderful segue to we have a practicing neurointensivist here. So we've heard the methodology behind this. When you're in front of a patient, Aarti, what do you do? And will this study change what you do?
Thank you for having me at one of these editorial videos. I think as a practicing neurointensive care physician who's been in this field for more than a decade now, we have always been biased towards feeding the brain more oxygen and more blood. I would confess that. These two trials, and especially this meta-analysis, almost confirms a practice that we have held behind for quite some time. So most neurointensive care physicians, in my opinion, have been biased towards a little more liberal threshold for keeping high hemoglobins. We've had some concerns after the initial TRIC trials showed the adverse outcomes related to more blood transfusions, mostly in relation to circulatory overload, in relation to ARDS in critically ill patients. With trauma and other acute brain injuries, I think we've kind of tried to balance that out on a patient-to-patient basis. But this Emotion and the Sahara trial really gave us a objective evidence to objectify that there is some value in the added neurological benefit that comes from giving them a little more blood. Now, from a bigger perspective, it hasn't really changed our practice. I think the practice has been in some acute brain injuries will pick up 9 as a target and some will pick up 10. I think the systematic review does make a good case of picking up a target like 9 to balance it out. Having said that, it still comes only from 2 trials with obviously their inherent clinical limitations. Bram did a pretty good job of talking about the statistical part of it, but one challenge that we've had in translating this more is 2 facts that make me feel that more research needs to be done in this topic. Number one, there does seem to be a significant heterogeneity in our clinical practice of how we manage these patients holistically. There's been significant literature that the adherence to Brain Trauma Foundation guidelines is not as consistent, even in the first world, as we expect it to be. And that does provide a significant clinical heterogeneity in the population and how it was managed, because that does impact the neurological outcomes a lot. The second big thing is the clinical bias in the class imbalance. So one of these trials had a very restrictive, I think it was the Emotion trial that had more patients in the restrictive strategy that had pupillary non-reactivity, which is a very significant sign of adverse prognostic outcomes. So that class imbalance of how the patients were randomized with regards to our measures of adverse prognostication, I think that does leave some room for addressing this in the future. But in general, this meta-analysis will confirm our widely held practices that the brain likes more blood and the brain likes more oxygen.
Thank you, Aarti. So I'd like to thank both Dr. Rochwerg and Sarwal for helping us to discuss this article, which you viewers may find in the April edition of Critical Care Medicine, Transfusion Practices and Traumatic Brain Injury, a systematic review and meta-analysis of randomized controlled trials. Thank you very much.